Welcome to EM Supply Room Series, Airway. You were working in the ED when you were called to the critical bay and see a patient that is sitting in the tripod position. She appears diaphoretic, tachypnic, and the monitor shows an SpO2 in the low 80s to high 70s. What do you do next? Protect her airway. Before you gather your airway supplies, first pre-oxygenate the patient with a nasal cannula and non-rebreather mask together. Also have your BVM connected to an oxygen source and have it ready just in case the patient goes apneic. To effectively ventilate the apneic patient, you're going to use your left hand to hold the mask and the right hand to ventilate. To hold the mask, make a C with your index finger and thumb. Then, place the middle, ring, and pinky fingers along the mandible to lift the chin up. Bag with your right hand. Manipulate the mask if an air leak is present. Look for chest rise and fall for adequate ventilation. If the patient is difficult to ventilate, you can use the two-person BVM technique. With this technique, you will hold the mask with two hands and the second rescuer will ventilate the patient. Adjust the pressure of the mask if an air leak is present. If you are still having difficulty ventilating, consider using an adjunct like an OPA or NPA. While the patient is being pre-oxygenated, gather your airway equipment like laryngoscope handle, macrometer blade, colorimetric CO2 detector, and Yankauer with tubing and canister. Consider using a 7.5 ET tube for females and an 8.0 ET tube for males. Have an ET tube one size smaller and larger available if the planned ET tube size is inadequate. Always have backup airway equipment, such as an LMA, bougie, glidoscope with a rigid stylet, and an 11-blade scalpel with a 6.0 ET tube if an emergency cricothyrotomy is indicated. It's very important to ensure your equipment is working. Inflate the cuff of the ET tube, make sure the glidoscope is plugged in and functioning properly. Also check to see that you're using the proper intubation equipment, like using a flexible stylet for direct laryngoscope or a rigid stylet for the glidoscope. Have suction at the bedside and verified dosing of sedative and paralytic medications for rapid sequence intubation. Remember, preparation is key. To successfully intubate, there are 4 anatomical landmarks we must know: the vallecula, the epiglottis, the vocal folds, and the trachea. Before starting intubation, the patient must be placed in a sniffing position, like sniffing a flower. This causes the face to extend and the neck to flex for optimal visualization of the vocal folds. This can be accomplished by placing blankets under the patient's head and tilting their head back. In larger patients, using blankets to create a ramp can be used to accomplish this position. It's important to realize to not attempt this maneuver on patients that are on cervical spine precautions. Once the patient is sedated and paralyzed, start the DL intubation by placing the patient in the sniffing position. Open the patient's mouth using the scissor technique with your right hand. Insert the Mac blade on the right side of the mouth and sweep the tongue to the left. When you see the epiglottis, advance the blade into the vallecula and lift upwards and away from yourself. This should expose the vocal folds. Remember, do not rock the blade backwards as this can cause dental trauma. Then, pass the ET tube through the vocal folds until the cup disappears. Slowly remove the blade and stylet. Advance the tube to 21 centimeters in female patients and 23 centimeters in male patients. Inflate the cuff. ET tube placement is confirmed with a yellow colorimetric CO2 detector, auscultation of bilateral breath sounds that are equal, and chest rise. Immediately insert an orogastric tube to decompress the stomach. Finally, order a stat portable chest x-ray. Videolaryngoscopy with bougie. With videolaryngoscopy, the technique is similar to a DL intubation, but with some differences. Place a hyperangulated blade midline and advance the blade. Once the blade is in the mouth, look at your screen and identify the airway landmarks. Now, if you're getting a limited view of the cords, you can use a bougie. Place the bougie between the vocal folds and slide your ET tube through it until the cuff disappears. Inflate the cuff and confirm successful placement.